I'm a professor of urology at George Makgatho Academic Hospital in Pretoria, South Africa. And I mean, when I was training I finished in 1996, I literally had 2 hours of discussion about sexual health amongst men. Because before the advent of essentially Viagra, we used to consider erectile dysfunction and men's sexual health as unimportant, really. It's mainly in the mind, we were saying. But the reality is that we now know that 80% of erectile dysfunction and a lot of the other sexual dysfunctions that men have are organic. We know that there's underlying diabetes, hypertension, hypercholesterolemia. We know that erectile dysfunction particularly is a cardiovascular disease. It actually, I'd like to put it simply for my patients that if you look at the internal carotid, the coronary, and the penile artery, you'll find that the internal carotid is a little bit bigger than the coronary, which is a little bit bigger than the penile artery. And if we know that, for example, diabetes, hypertension, hypercholesterolemia, it's not about sugar, it's not about cholesterol, it's about damage to the endothelium, the inside coating of the blood vessel, the endothelium, causing atheromas. So if you have red blood cells flowing into the brain, that blood vessel's a bit big, you might have a bit of an atheroma, might be a problem. Coronary, same thing. But you get to the penile, which is slightly smaller, and you start getting erectile dysfunction, which lasts more than 3 months, by the way, because guys, we all have a bit of a failure as well. All guys have a bit of a failure once in a while. But the point is that if it's consistent for 3 months, you have an 11 times increased risk of heart attacks, strokes, loss of limb. So sexual health is extremely important for general health. And I think we have to remember that we also have to be open-hearted to our discussions, because we know from data that about 80-90% of patients are open to discussion about sexuality. But the same number of physicians don't want to discuss it because they don't think it's important or they don't feel comfortable. And I know a lot of people won't feel comfortable about it, but at least if you do find a patient who comes in and they have some form of sexual dysfunction, which I would encourage you to ask, and you don't feel comfortable discussing it, at least refer it on to somebody else, because you're going to be preventing that guy from dying from a heart attack, a stroke, or loss of limb. I think it's important not only for their general health and their mental health, but also for their physical health, because we know that when patients have diabetes particularly, at least 90% of men have testosterone deficiency syndrome, 90%. That's why in the NICE guidelines, for example, it's been put that you have to do a testosterone level as one of the baseline tests when you're checking a patient with diabetes. And we know that testosterone supplementation can decrease body fat in diabetic patients and also help with their HbA1c control as well. So I think any patient who comes to a general practitioner or a family practitioner or urologist or any other specialist, if they are diabetic, you have to ask about their sexual health, particularly when it comes to testosterone. We like to talk about their feelings of having sex, decreased libido, or what's going on. Also remember that there are 3 types of erections. There's the psychogenic, the one that most people consider. There's the reflexogenic, which is a stimulation of the bulbocavernosus reflex. That's why paraplegic patients can also get erections, and most of them are relatively young. And then the third one is nocturnal erections, which happens even in young boys. I mean, we know that 12 to 15, the young boys get 12 to 15 erections every night, and it's all about oxygenation. And we know that if you're not getting morning erections as an adult, particularly if you're diabetic or anything else, you often will have a low testosterone, and supplementation can benefit not only your general health, but your sexual health as well, and also its impacts on responses to medications that we use for erections, such as the PDE5 inhibitors. I think that's such an important aspect of urology and general health for men. We know that prostate cancer is the second commonest cancer after skin cancers worldwide, and it's the second leading cause in most countries, including South Africa, for death after lung cancer. And again, I think this harps back to what we talked about men's health. I think guys in general don't take our health seriously enough. We know that the average man sees their treating physicians or practitioners 5 times less than females. And that's why females, barring any comorbidity, actually have a 6-year greater lifespan than men. And all we really need to do is just take a little bit of control of our health, and including our sexual health. And I think when it comes to, for example, prostate cancer, we do know that Black Africans particularly have an increased risk and they're more likely to die from it. So we usually start doing screening for prostate cancer around the age of 40 in South Africa. I think worldwide, it's particularly in Asia, because there's a lower risk of cancer. 50 is very reasonable. We've had a flux because the problem was that we were overdiagnosing and overtreating prostate cancers, because we know that 50%, if you live long enough, everyone gets prostate cancer, every guy will get prostate cancer. But about 50% of them are Mickey Mouse, they're nonsense, they're not going to give you trouble. And we don't want to be treating them because, like you were mentioning, is that there are side effects of treatment. And just to take a step back, if you pick it up early, usually with a PSA, and that doesn't have to be done more than once a year or once every 5 years, depending on the level, and you pick it up and you do a biopsy, find a cancer, if it's localized, 95% cure, regardless of what treatment we do. But I think what we've done now, we've changed, we've gone back a little bit, because like you were saying, Dr. Swatsky, that there are three main aspects of treatment of the trifecta for prostate cancer. One is oncological control, making sure the cancer doesn't spread. If it's localized, regardless of whether you have radiation or radical prostatectomy, but 95% cure across the board in general. Depends on, of course, the staging and stuff like that. The second one is continence, that's urinary continence, and we do know that there are some side effects. For example, radical prostatectomy, we have anywhere between 2 and 20% chance of stress urinary incontinence or total incontinence, which can be treated by various things as well, and usually gets better after about a year. Radiation also can cause a bit of overactive bladder, rushing to the toilet in about 2 to 5% of men as well. They are the side effects, but most of them are relatively easily treatable. The third one is erectile function, because remember, the main blood vessel to the penis, coming through the pudendal, it goes into the corpora, it's running right next door to the prostate. So if we do any form of active treatment for patients with prostate cancer, we are looking anywhere between 20 and 40% of guys having erectile dysfunction. It can be treated as well. But that's when we come back and we look and we say that if you get picked up early and you've got a patient who's got low risk prostate cancer, the majority of them should be going on to active surveillance, which means that we're just following the patients up. We do MRIs here and there, or do re-biopsies as necessary. Cure rate 95%. About 40% of them will eventually have to go to active treatment over a 5-year period, but you're saving the patients from a lot of the issues with the erectile dysfunction. When it comes to benign disease, remember that none of the treatments that we have for surgical treatments have a direct impact on erectile function for the majority, but they do have an impact on ejaculatory dysfunction. So all of these things, be it for prostate cancer or for BPH, if you're putting them on treatment, a medical treatment, or if you're giving surgical treatment, often they will get either retrograde or ejaculation or emission issues, and that has to be discussed with our patients. But in general, the side effect profile for benign disease is much less than for prostate cancer. I think we must remember that chronic kidney injury is one of the biggest killers for our patients as well. We know that the vast majority are caused by by diabetes and by hypertension. It's not usually from obstruction, from prostate cancers or anything else. It's almost always going to be diabetes or hypertension. It's an intrinsic damage because of vascular as well involved there. It's very important for us to address it and treat it. But when it comes to sexual function, remember, sex is a form of exercise. And exercise is important for general health. So the more sex we have, actually, the better it is. In fact, French data has shown that if you have sex after the age of 60, twice a week rather than twice a month, you increase your longevity by 6 years again. So sex is super important, even for patients who are in renal failure. Renal failure can have so many impacts on various aspects of life, but the point is, it also is, because it's actually also a cardiovascular disease, it's also going to increase the risk of erectile dysfunction, also of testosterone deficiency. So the short answer is that if the patient is fit enough to do a bit of exercise, he should continue with his sex. And our treatment protocols are pretty much the same. We've got different levels of evidence. If it's mainly about erectile dysfunction, the first line of treatment is going to be one of the PDE5s. We've published on this as well that PDE5s retrospective data seem to have a protective effect against heart attacks because as you know, the original PD5 was discovered it was originally produced as a antihypertensive medication, and when at the end of the trial, when it didn't meet its endpoints, the guys weren't bringing back the medication, and that's how Pfizer picked up that it was actually good for erections. It actually protects you because what it's doing is it actually causes what we call endothelial regeneration in some patients. It's relaxing the blood vessels. So you should feel free, provided the patient is not having one of three things. One is if you're going to put them on a PD5, they mustn't be on a nitrate, regardless kidney injury or whatever. But if they're taking a nitrate for angina or whatever, they can have precipitous drop in blood pressure, which can kill them which can be fatal in patients. So if they're on a nitrate, no. If they've had a recent myocardial infarct, in other words, within the last 3 months, again, it's not directly related to the kidney, it's the heart that's the biggest issue for most. And what we mean is that if it had a recent MI within the last 3 months, they shouldn't be on it. Again, not because the drug is dangerous, but because they shouldn't be having exercise. And sex is a form of exercise. But if once the 3 months are out, PD5 is excellent treatment for the patients, and they may protect them from further heart attacks. The third one is if they're in congestive cardiac failure. And again, not directly related to the kidney, but with the heart. Again, the reason why patients with uncontrolled CCF cannot take a PD5 is again because of exercise. They shouldn't be exercising because it can cause them, it has adverse effects for those patients. But besides that, if the patient is otherwise fit, treatment with PD5s or with penile pumps can also be used. Injectables, you should be looking at the testosterone level for almost every patient who has, male patient particularly, who has sexual dysfunction. Although, by the way, female sexual dysfunction is very related to testosterone as well. And we're now doing trials on females about their testosterone levels and supplementation, particularly in patients with breast cancer, because we know that topical application of testosterone to the vagina is not detrimental to the hormonal breast cancers. And once you've done all those, you're going to be improving the outcomes for your patients. And remember, we're now pushing more and more to medicine about patient-related quality of life. And quality of life is such an important aspect of our patients. Even if I always tell my residents that if you must ask them what the problem is, but does it bother you? If it doesn't bother them, it's fine. But if it's bothersome, no matter what their situation, we have to look at aspects of treating it. I'll give you a prime example which led to a treatment protocol. When we have patients with prostate cancer, which is metastasized, we know that the standard of care is to do androgen deprivation, whether it be for orchiectomy or whatever. And again, another good reason for our patients to pick it up early so they don't have to get testosterone androgen deprivation. But we've had many patients who are on, when you're on androgen deprivation, you do get sexual dysfunction, you get hot flashes, you get osteoporosis, you get mood changes. A lot of our patients say, no, this is terrible. So we know that some of our patients with castrate resistant, because when you're on palliative treatment with androgen deprivation, eventually your patients will get castration resistant and they're not going to be responding to the androgen deprivation. And some of my patients come and say, listen, I know I'm going down, I've got castrate resistant. Can you get my testosterone back? Once you've been on androgen deprivation from a GnRH or whatever, it takes a long time. So some of my patients, once they signed and said, listen, they're willing to have the testosterone supplementation, even though it's probably going to stimulate their prostate cancer, I've given it to them. Their quality of life improved. And now this has led to a trial now where, because it looks like the outcomes for patients with castrate-resistant prostate cancer, if we push up the physiological levels to super physiological levels, it actually stimulates the good prostate cancers to return. And it actually has a benefit for survival as well as quality of life for patients with castrate-resistant prostate cancer. So I think we have to just make sure that we discuss with our patients, make sure we're not getting ourselves into trouble, but also let's not stick to the dogma that, for example, that you have to always have testosterone deficiency, you must be in castrate-resistant, you must keep the androgen deprivation going. It may not be that. The trials are still in progress, but I can already tell you that I've had a number of anecdotal patients who I've put on testosterone, who have been on androgen deprivation and they were castrate-resistant, who have still having good longevity from off the thing, plus quality of life. When we see our patients, there are only 5 things. I'm in Africa, we have the big 5 in Africa, but the 5 things are so important before you even initiate any other medications or treatments. Number 1, exercise. The best pill you can take. And it doesn't have to be too much exercise. We've got data from Birmingham, randomized control, which showed that high intensity HIIT training, literally 2 minutes, 3 minutes per day, just from speaking, has the same benefits as an hour and 20 minutes of standard exercise, as far as your heart goes. It's not difficult to do. It's not difficult to do a little bit of exercise. Second, the diet. And it's not about what you eat, it's the numbers of calories we know. Because if you're eating a low-fat, big bag of chips, you're still going to get calories from that, which is going to cause you problems. So it's the numbers of calories. Doesn't matter whether you're getting them from fat or from meat or from protein or whatever, numbers of calories. Third, and I don't like to pontificate, but the most important social decision that anyone can make as an adult is to smoke or not to smoke for your health. Smoking damages everything, increases your cardiovascular risk, increases your cancer, every cancer, by the way, including prostate cancer. If you are smoking, please stop it if you can. If you're not, then don't try this. Don't start if you can, because it's so important. And that brings us to the 4th problem: stress. Talking about it's stress from COVID, the lifestyle generally. We know from preclinical data with rat models, when we expose them to stress, which usually is by putting tobacco smoke into the cages, and then when we sacrifice them, we find that their cytokines being released by the brain because of stress, which is then going to cause you heart attacks, strokes, loss of limb, erectile dysfunction. No stress. And then any other drug in excess, for example, alcohol or any other type of drug in excess, can cause a problem. And those are the 5 things you must just discuss with your patients before you decide on other treatments. The other treatments can be initiated at the same time, but these behavioral changes are so important for the general sexual health. And I think when you were talking about the stress, one of the things to remember also is that the most common sexual problem for men is actually premature ejaculation. And premature ejaculation happens to about 80% of guys at some stage in our lives. And again, guys, if it happens once or twice in a year or occasionally, it happens. These are things, it's natural. If it's consistent, and for example, we have data to show that 20% of men have congenital premature ejaculation. In other words, from the first time they've tried to have sex, they've had premature ejaculation. Huge stresses, causes them to be under lots of pressure, gives them issues. It is treatable. It is treatable because, first of all, we have to just take a general health, make sure that there's not neurological bits and pieces. But we now know that the main cause of premature ejaculation is serotonin, low serotonin in the brain. And so off-label, in most countries, there's duloxetine in America approved as an on-demand. But in general, most SSRIs or SNRIs, if you're given on a usually best on a daily basis, if they don't get side effects, we'll stop their premature ejaculation. And remember, premature ejaculation, we used to say it was either before you penetrate or within 30 seconds of penetration. That's changed now. It's about bother. If it bothers a guy, if a guy is going on for 5, 10, 15 minutes and he ejaculates and he thinks it's not long enough, that's when we can address it. We must deal with our patients, not with textbooks. And if you are put on treatments, including there are behavioral things like withdrawal, pinching of the penis, there are topical anesthetics. But in general, the SSRIs and SNRIs work very well for the majority of our patients when they have premature ejaculation. I think medicine particularly is such an honorable and such a joyous and fulfilling profession. The majority of doctors are going there not because of money. We don't have a bad living, but it's mainly about quality of life for ourselves as well. Once we lose that, we're going to lose both our happiness and as well as our profession. And I think the important thing is about giving back. First of all, remember, you must give back first to yourself. Make sure that you don't burn yourself out. If you're under pressure, you think that you have to do things, you have to go to the hospital. No. If you die, or you get a heart attack, or you go into severe depression, you're going to be out of service and not going to be able to help your patients, let alone yourself. So first of all, look after yourself. And again, the big five: exercise, diet, no smoking, no stress, not excess. You can take care of your health. Second is to make sure that you actually do impart knowledge not only to your patients, but to other people as well. It's so important, like for example, with MedSynapse, you're giving out so much information that's helping the vast majority of our medical community. And once you do that, it becomes so much more fulfilling. But once you decide on that, you can also incorporate spirituality, religion, whatever is necessary, but you have to be comfortable. There's no one right way to live. The only way for you to live is to take care of yourself, first of all, and then make sure that you then spread that joy to other people as well. I think men's sexual health in many ways is outpacing female sexual health, mainly because of 1996 Viagra. That's when we started doing more research and using standard methodologies to do things. We're progressing. There's so many aspects that are going to be going forward. We're using, for example, for erectile dysfunction, we're using a shockwave lithotripsy. We're investigating about hedgehog signaling for paraplegic patients to regenerate their nerves for things. There's so many aspects that are coming up, but I think even when it comes, for example, to contraception, we're now on our way to the male pill, which is going to be, it's based on a lot of different aspects. There are lots of different ways of investigating it, but it's so important for male sexuality to be pushed forward as well. And one of the biggest issues for guys is that we, again, think that we're macho, we're tough guys. We have a problem. We're not going to go and see anybody. We're not going to get treatment. We'll just suck it in. It's causing you stress. Causing you problems, and you're probably missing an opportunity to prevent heart attacks, strokes, loss of limb cancers. We need to take better care of our health. And going forward, the female sexuality has been left behind a little bit because of there was no male-female Viagra at the stage. Now there are some medications that we use for various aspects of female sexual health. I think the interaction between partners is so important as well. And that's why the intimacy that you have with your partner is also an aspect which improves your general sexual health and your mental health. So although masturbation, that's something, there's no danger from it, but it does miss out on the intimacy part. And I think we need to just start becoming more interactive. I know now we're all wearing masks all the time. We barely see what other people look like, but you need to find some way of getting some human contact with other people. And even if it's with your patients coming to see you as a physician, that can be a huge impact on their general health and even their sexual health, to make sure that they understand that they are not alone in their journey. It's not just about education as well. I think it's just a matter of our, because we always like to say in sexual health that it's a bio, psycho, social, cultural model. So there's biological aspects, for example, the diabetes, this, that, and the other, testosterone. There's the psychological, huge. The biggest sex organ in the body is the brain. If you're stressing, 90% of sexuality is there. And if you're stressing about ejaculating quickly or erectile, or you're not worried about it, it can cause huge impact. You must also look at the social, the interactions. And again, I always tell my patients when I'm giving talks that for adults, consenting adults, there are only really two sexual problems that I would find criminal. One would be rape, taking somebody by force. And the second is almost the same thing, taking a child. Besides that, in a consenting adult environment, do what you want. I always like the example that I have a patient who could only ejaculate when there was a red shoe next to his wife's head when they were having sex, and they were battling to have a child. And the wife thought it was terrible. But I said, listen, I don't think the shoe is upset. Why don't we put the shoe there and see? They now have 2 children, so I'm pretty sure there's a red shoe somewhere involved here. It's not dangerous. Let's all relax, take ourselves properly, and see what happens. Fourth, cultural. There are different cultural aspects when it comes to sexuality. For example, in East Africa, the majority of women will only have orgasm when not from penetration, but from stimulating of the clitoris with the male organ, and 70% of them. And it's the way that their culture has brought them up, and they're comfortable with that. So again, I think we need to just make sure that we are comfortable with our sexuality, make decisions which are not impacting or hurting other people, no rape, no children, but otherwise, whatever you feel comfortable with, please go get along with it and see how you do. As a urologist, I had so little training when I was in my undergraduate and in my postgraduate degree. But for GPs and for family practitioners and other specialties, it seems like it's a daunting task, but it's going to improve your outcomes for your patients. Second of all, it really doesn't change much of your general history examination and general and investigations. You just have to just bring it in. Just ask them, do you have any problems in the bedroom? That's the way I usually bring it up. Are you having any issues with your manhood or anything? Yes, no. If they do say yes, then it's just a couple of questions. Are you having premature ejaculation, or are you not getting good erections, or do you have low libido? 3 questions, you're done. And you can then direct them to their appropriate treatments. It's literally taking you 10 seconds, 10, 15 seconds. It's part of your standard investigations. It makes your patients, 80% of them want to have the discussion, and you're giving them the opportunity to say no if they don't want to have the discussion. So again, let's bring it in. It makes our lives easier. It makes our patients happier. Quality of life for everybody is better, and you don't have to, and you will be saving your patients, a lot of your patients, from organic conditions which could kill them. MedSynapse is doing such a great job of spreading information. You guys are doing you're helping us all. So thank you. The honor is actually on me.